That'll teach them. All the ones who are not on here. Yeah, so a lot of this stuff is trivial. And I think we spend more time like learning trivial stuff than we do the important stuff. I'm going to have to start labeling things like with a TR beside it. Interesting, but of no practical use. But it isn't, is it? A lot of this stuff just doesn't make any difference to you. You know that 50%, let me think of this, and I don't honestly know. Let's say that lung cancer is more common. 2/3 of lung cancers are in men and 1/3 is in women. Does that help? You know, even if it's 10-1, it shouldn't make any difference to the diagnosis. What it should do is make you think about the diagnosis once it's made. This is base rate neglect, isn't it? That you make a diagnosis based on something, but the chances of that diagnosis being correct is so low that, and you're just ignoring that lowness. But the fact is, if you do it right, that lowness is actually a biasing factor against you making the right diagnosis. Yeah. So I don't think base rate neglect is really a good argument for anything except looking at the diagnosis and questioning it afterwards, after you've made it, and then see if you can think of something that's better by doing differential diagnosis. But as a piece of information, it doesn't really help you make the diagnosis. It makes you question it, but that's all. And if you question it too much, you end up doing what doctors do. Well, we're not going to x-ray your lungs because it only doesn't happen in children. Lung cancer doesn't happen in children. Well, if that's 100% true, then they're right. If it's not 100% true, then they're wrong. Yeah. There's an axiom. You treat the patient, not the numbers. Yeah. So on those two questions, 7 and 8. Where are they? I've got this up somewhere. Where is it? Oh, there it is. Okay. If you had to pick two, which would it be?
For 7 and 8?
Oh, for 7. If you could pick two answers, which would they be?
Well, the least consistent, I would say, is deep, dull, diffuse pain.
Yeah, and? Anybody else want to join in?
Classified as chronic pain. I don't know if I would.
Yeah, I would pick the middle two as an option for the answer.
Well, occipital-frontal pain is actually the distribution of a spondylogenic headache, isn't it? Just said that, didn't it? It comes up over the top. So that's consistent with it being, not least consistent, that's consistent with it. So this may be the question, you're misreading the question. What is least consistent with a diagnosis?
Least consistent.
So this is a case in point of actually making sure you understand the question. Yeah. Most people have had headaches for a long while. Yeah. So you're left with the first two, really. Take your pick. Actually, you can even think about that in a different way, rather than actually technically the answer in the question. Because I could have asked it differently. Which of the following presentations is the most serious? Which one do you think? Which one is the bleed?
The deep, dull, diffuse
pain. Yeah.
Yeah.
So the question could have been asked that way. Which of these is the most serious, potentially the most serious pathology? Yeah. Question 8 is actually a reversal of question 7, which is the most consistent with the diagnosis of sphycogenic headache. You just discussed this, James, didn't you?
Yeah.
Traumatic.
Yeah.
So this isn't like a typical, I don't think this is a typical multiple choice. This isn't as simple as most of the multiple choices, I don't think. You have to read the question, you have to understand the question, and that once you've done that, then the answer becomes a lot simpler. But if you look at this superficially and don't read the question properly, you're going to get it wrong. Yeah. Any other questions in there you want to talk about? No? It'll be a short meeting.
I just got to pull mine up. Could we talk about 21?
Patient presents with vertigo. Which of the following groups of associated characters would make you most comfortable that the patient is not suffering from dangerous pathology? So this is about what is peripheral vertigo. Yeah. Short duration vertigo, downbeat, nystagmus. I mean, straight away, you know that's bad. Downbeat nystagmus is always serious pathology, so it's definitely not that one. Short duration vertigo with lateral nystagmus, long duration vertigo with lateral nystagmus, long duration vertigo with downbeat nystagmus. Well, you've got downbeat nystagmus in 2 of them, so there ain't them 2. Yeah. Now, is short duration or long duration typical of peripheral?
I think shorter duration. Longer duration, I think, is
You may
more.
be right. You may be right. All right. So you work your way through this. You like the 2. Well, there's 3 distractors there. Obviously, 2 of them are obvious. Downbeat and nystagmus. Yeah. Anything else? A lot of this stuff, like question, this is a good case in point. Vertebral artery fibromuscular dysplasia is what? Now, I haven't told this, have I? But it's in everything you've got from me. It's in there. All right. So don't forget to do some work on this. If you just rely on what you learned in the classes, that was pitifully short because we just didn't spend enough time to do as much theory as you need to answer this. So you've got to do some work on this. Yeah, you've got. I'm pretty sure I sent you a link to a couple of narrated PowerPoint presentations on my website on vertebral artery pathologies, and there's a lot of stuff in there. So you've really got to start doing some of this stuff, otherwise this is going to be a painful, very painful experience for you. Okay. Anything else in there?
Could we talk about 30 as well? So after a manipulation.
Which of the following signs would most alarm you in a patient whose neck you had manipulated the previous day? Significant increase in pain, significant decrease in range of motion, tingling of the lips, or dizziness? What do you think?
Well, dizziness would make me think VBI, potentially. But then we also talked about sometimes it could be proprioceptive.
Most
after
times it will be
7,
proprioceptive.
right?
Most times it will be. All right, you've made the pain worse. In fact, I did a webinar on this, so you made it worse. Don't know if any of you looked at it or not, but there's a webinar on this, fairly recent one as well. You might want to look at. But if you look at those symptoms, yeah, you're going to make some patients worse when you treat them. So there's going to be an increase in pain. If there's an increase in pain, you're going to have a decrease in range of motion. Now, you worry about those two things if it occurs immediately. If it occurs later, then it's inflammatory in nature. The dizziness is another case in point. If I manipulated somebody and they immediately got dizzy from that, that would concern me as well. But we talked about tingling in the lips last weekend, I think.
Yeah, you did.
Yeah, and this is vascular. Now, it's either a panic attack or it's vascular. So unless they're panting out of panic, which is, they'll get it then as well. If they're not doing that, then you have to worry about tingling. Okay.
So would you be more worried about that than dizziness?
Yeah.
Thought so.
Yes, I would. Again, though, it depends on how, but like even if the dizziness started immediately on the manipulation, tingling in the lips is not something you come across. When's the last time anybody came across this? You know, and it's the cause of it isn't well understood why this happens, but it's very much established as a consequence of neurovascular problems. So you've got to go with the experience of clinicians. Just can't explain it very well. There's a couple of explanations. Probably the one I like best is an aberrant artery, the superior cerebral artery that supplies this part of the cerebrum, actually the bit that does the lips. All right. Anything else?
Can we talk about 32, please?
32. Which of the following scenarios about type 2 dizziness induced during VBI tests would make you most suspicious that VBI was present? It was associated with C6 paresthesia. Okay, it was present when the trunk was rotated under their head. It was short-lived after the provoking position was relieved. It was long-lived after the provoking position was relieved. That's an interesting one, that. I'm not even sure what answer I gave on that. I can think of two possibilities there. So what do you think? I'm pretty sure I know what the answer was I put on there. Again, get rid of the distractors if you can. It was present when the trunk was rotated under the head. Would that make you worry about it being VBI? Not really, because that isn't about VBI, is it? That's about the labyrinth. When you rotate the trunk under the head, the one thing you're taking out of this is the labyrinth. Yeah. And given this is type 2 dizziness, not type 1 dizziness, we're really not thinking about labyrinthine problems. So that could easily be proprioceptive problems in the neck. Short-lived after the provoking position was relieved. Is that typical of peripheral or central dizziness? Well, vertigo now. We got trouble with the type 2, but let's say this is vertigo for the moment. Is that a problem? If this is vertigo, would that suggest central or peripheral?
That sounds more peripheral.
Sure.
Yeah, and basically what I said to you was that anybody who's got type 2 dizziness who isn't getting better within about 10 minutes, you should be concerned about.
It's very short-lived, yeah.
It's got better. Yeah, it gets better. So you're left with the last one. It was long-lived after the provoking position was relieved. And the other one was it's associated with C6 paresthesia. So basically, when they got, what did we do? We manipulated them. Nope. They're coming in saying, when I get dizzy, I get pins and needles in this area of my hand. Or when I get pins and needles in my hand, I also get dizzy. So what sort of scenarios have you got for that? Listen to her. She's probably giving you the answer there.
No, she's not.
So have you got a mechanism for that?
Okay, good.
Do you have a vascular mechanism for this? Really? What supplies the neural segment? It's a radicular artery, isn't it? So if you've got a block on one of those arteries, then it could do this as well. Yep. So you have to figure that one out. You have to have enough anatomy that you can work through that problem. This is what I mean. This isn't like a university's multiple choice. This isn't just fact-based. In fact, I don't think many of these are fact-based, are they? It's not, most of this isn't asking you to regurgitate facts. It's asking you to interpret stuff. So 33 is interesting. Which of those contraindicates lumbar manipulation? Go all by itself. Forget everything else. All by itself. Pick one. Or do you think they're all okay? But that's not the question, is it? Obviously, one of them is, you need to answer one of them.
I would say the straight leg raise.
Okay. Anybody else want to kick in this? Well, what do you think about moderate pain in the low back and buttock? Is that a contraindication? It's an indication. Limited trunk flexion. It's an indication. Instability above the level to be manipulated. Protect it. What does it leave you with? It only leaves you with one. So you can do this negatively. There's still reasoning. Do it negatively. Yeah. Any others? How far did you get through this anyway? Did you manage to get them all done? Not many, is there? There's only 48 here. The one that really screws people up is that, like number 41, match the test in column 1 with the anatomical area in column 2. Because if you get one of them wrong, you get no marks for that answer.
Yeah, right. Yeah.
Yeah. Although I have changed that a bit, I think. Or I was going to change it. So maybe I haven't changed it, or I was going to change it. You'll find out. But yeah, you need to be aiming for all of these. The last one, if you got everything else right, falls into place, doesn't it? It can't be anything else. Jaw jerk.
Vestibular labyrinth.
Midbrain.
Why? Why the vestibular labyrinth?
We were checking out
You're doing a cranial nerve exam.
exam.
Yeah, but why the vestibular labyrinth?
Because it's the same nerve.
Well, it's not. The vestibular labyrinth is 8, isn't it? Jaw jerk is 5. So it's trigeminal, so it'll be midbrain. Yeah. So again, you've got to know the test, you've got to know the anatomy. This is not an easy quiz. It really isn't an easy quiz. Anything else there? Facial paresthesia should be considered evidence of which one of the following. This is all by itself now, okay? Standalone symptom. Trigeminal neuralgia, facial nerve compromise, trigeminal segmental facilitation, midbrain ischemia. That's a bit of that's an unfortunate question there. I'll have to change that one. But think about it. I'll give you a choice of two answers there. Pick one of them. So what supplies the skin of the face?
Trigeminal.
Trigeminal. So this is either trigeminal neuralgia or midbrain ischemia. Yeah, it could be either one of those two. I do need to change that. Now, the people who are not getting involved in this, and that's everybody but James and Harsh, you need to be assessing how well you did with these questions. All right. But right now, you've got some work to do. A lot of this is applied anatomy. A lot of it is applied pathology. But this is not a simple multiple choice question. All right. The questions are complex. Once you know what the question is, then the answers are easy.
Could we look at it? It doesn't really matter, 37, 38, or 39. It just gives like a scenario, and everything else being negative, would we manip?
All right, patient presentation includes moderate loss of range, moderate right low back pain, referral to the right buttock, right trunk deviation on flexion, all else being negative. This patient is a candidate or not for manipulation. What do you think? What's making you think it might not be?
True. I think true.
Yeah, I mean, there's nothing really there that says you shouldn't do it, should there? It's moderate loss of range, moderate right low back pain, referral to the right buttock, which is not extensive, and right trunk deviation on flexion. So what made you hesitate about this one?
That one, not so much, but I just feel like at either 38 or 39, I'm missing something.
Patient presentation includes minimal loss of range, severe right low back pain, referral to the right buttock, right trunk deviation on extension. All else being negative, this candidate is a candidate for manipulation.
I think the severity of the pain would make me not for 38.
Yeah, the severity of the pain and the fact there's minimal loss of range.
Yeah.
So what the hell would do that? I mean, this is where it looks weird. So given just that information, I will manipulate this patient because I can't make sense of that at all. Yeah. Patient presentation includes moderate loss of range, moderate right mid-cervical pain, referral to the right trapezius, left-sided headache. Yes or no? What's causing the headache? What do you think is causing the headache?
Moderate loss of range in lower C spine.
Where's the pain? Where's the neck pain?
All on the right. Well,
Right.
yeah.
So where did the headache come from?
The left side, yeah.
Yeah. So again, you're left with a quandary. But again, this is a matter of reading the question, not putting your own interpretation on the question. This is what the patient will say to you, and you automatically make it all about the right side.
Mhm.
Yeah. This happens all the time. I see this on when I'm doing stuff with people in the clinics. Like, where's the headache coming? Oh, it's coming from the neck. Really? Was it referred from there? Yeah. When do you ever see referred pain cross over body lines? Yeah. Like some of these are straightforward, aren't they? Match the cranial nerve test with the cranial nerve in column 2. Tongue protrusion, smile or frown, consensual reflex, trapezius reflex, facial sensation. You've got the cranial nerves there. This is a very straightforward factual question. This should be a gimme.
Yeah.
Yep.
Yep.
This last one we hit, cervical rib patient who requires vertebral manipulation, safe candidate providing the lower cervical spine is protected from the force of manipulation. It's false. Because it means there's a congenital anomaly causing the rib problem, which means they will have a vertebral artery problem. Yeah. So there's all sorts of stuff. You just have to read the question better or properly. Limited P pivum and pavum plus mild to moderate pain are sufficient findings to justify the use of manipulation. True or false?
Let's say
True.
false.
True. False. Which?
False.
True.
Why?
Like it says that we can use manipulation, but we don't know about minimal decline or.
Now, again, you take that as the information you've got, not whether there's a contraindication present or not. But given that information, and all else being equal, there are no other contraindications. Is that patient a candidate for manipulation?
Yes.
Okay, now make the most precise statement you can make, given that the P pivum and the pavum is positive. What's the most precise statement you can make?
Segmental dysfunction.
Now, you can be more than that. What structure is affected?
Mostly Z joint.
Well, the joint, not necessarily the zygapophyseal joint, but the joint. That's what the glide does. It tells you it's a joint. Now, what's wrong with the joint?
It's
Hypomobile. There's
Yeah.
hypomobility.
What's causing the hypomobility? Is this a pericapsular restriction? Is it subluxation? You can't be precise enough to say that this needs manipulation. It may need stretching. Yeah, so the answer is false. Actually, even the question is actually that's not limited. Oh no, it's limited. It says limited. If I had just said positive P pivum and pavum, this could have been hypermobile as well as hypo. But I did say limited. But you don't know what the limitation is, whether it's the capsule or pathomechanics. Yeah. They're not trick questions. They're really not. An intramural tear is one where the adventitia is intact. True or false? Don't know?
Sure.
Because you need to read it. You've got to look at this stuff. You have to go. You can't do it from the class. I'm telling you that right now. You will not pass this from the information you got from the class, which is why I'm giving you a month to get this done. Pseudoaneurysm is the same thing. Fibromuscular dysplasia we talked about. Hyperplasia you should know. So is that true or false? Vertebral artery hyperplasia is defined as, actually, yeah, vertebral artery hyperplasia is defined as one artery being smaller than the other. Is that true or false?
What number is that?
That
Oh, okay.
is 26.
It's 26, yeah.
True or false?
It's true.
No, it's not. One artery is almost always smaller than the other. Hypoplastic artery is so small it might as well be absent. So this is an artery that's smaller than 1 millimeter in diameter. Here's a nice factual one for you. Most common point of entry for vertebral artery is into the transverse foramen at C5. C6. But the fact is 26 was a factual question as well. If I had said what actually makes an artery hypoplastic and then give you a choice of being smaller, being 1 millimeter in size, being larger than 3 millimeters, then you'd have probably got the answer. But this is not the way the world works, certainly not the way this exam works. The ptosis of Horner's syndrome is caused by paralysis of levator palpebrae. True or false? I know I mentioned this one on the class once, I think. Any thoughts? Which is Muller's muscle. They pull on the tarsals, the fibrocartilaginous plates in the eyelids. So it's a very small muscle. Ptosis from levator palpebrae, it's a huge ptosis. This is fairly minor in comparison. So, am I getting the point across here? You've got work to do, fair amount of work as well. All right, and read beyond the manual. You got the PowerPoints I've given you on the USB. You got the PowerPoints on my website. You've got all sorts of stuff, and you've got this to guide your studies. All right. If you haven't looked at this yet, then look at it for next time. We'll do this again, but go through this again. Be critical about the answers, and if you're not sure of an answer, bring it up. Okay. There's only 48 on there. You good?
Can we check out question 12, please?
Which one?
12.
12.
12.
Which of the following conditions is least likely to cause non-fracture anterior instability of the atlantoaxial joint? That one? Tolu?
Yes, that one.
Okay.
Chronic tonsillitis.
Rheumatoid
Least likely.
process, least
Trauma.
Trauma. Trauma or fracture. It won't tear the ligament, it'll fracture. So that's the least likely of the four. Again, what was you thinking, Tolu? The most likely?
The least like to cause non. Oh, okay.
Was you actually thinking of most likely, though? You can read
Most
it now.
likely, yeah.
Yeah. So you've got to make sure you read the question.
Question,
But the thing is, if that was most likely to cause a non-fracture instability of the atlantoaxial joint, I'd have trouble figuring out which of those it is. I know which one it isn't. That's trauma. But I'd have trouble. I don't know the incidence of these diseases well enough to say it's rheumatoid arthritis or chronic tonsillitis or Rhinitis disease.
Right.
I don't know. So if you look at the answer there, it tells you that's unlikely to be the question, especially when you know me. Yeah. I'm not that much of a bastard. I'm close at times, but I'm not that bad. So you have to read the question. Anything else on there?
$18.
Yeah. 18.
Yeah.
Which one of the following is usually the cause of most severe vertebra?
Vertigo.
Think about this. What disease will cause the most severe vertigo you can imagine? It's so bad that they have to lay there in a dark room and close their eyes and not move. Sometimes not even think about moving. You can't think of a single disease that would do that?
Head injury.
Hernias. Yeah. Labyrinthine pathology. Yeah.
Most severe.
Yeah, most severe. Because if that was 18, wasn't it?
Yeah. Yes.
I'd have trouble answering that. If that was to ask the least severe, I'd have a hell of a job answering that. What you're doing is you're putting your own interpretation on the question, then misreading the question. That's exactly what you're doing. And it's amazing how certain you are of what you've read. Read the question, look at the question. Does it make any sense? If it doesn't, reread the question. If you can answer it easily, you're probably right, but reread the question anyway. You cannot read these questions enough, and read one word at a bloody time, because you're skipping it. You're reading the way people scan. You are reading the way most people read. And what they'll read is they'll leave words out. If they're reading a sentence in a book, words get left out because you can patch them in afterwards. Whole letters get left out. You don't want to be doing that with this. This is not a casual read. All right. So really concentrate on what you're doing. All right. That do you? I would try and get at least one of these done a day. All right. Be critical about it. Read around it. As I say, you want to use this as a study guide. Like almost everything that I think is important as far as the theory of this is concerned are in these questions. So these can be used as a very nice study guide. This isn't so much about passing the exam. This is about studying the theory on this course. Okay. Oh, quickly before we leave, which one of the following is not a sign of Caudery-Quiner syndrome? Multi-segmental motor paresis, multi-segmental hyperreflexia, multi-segmental sensory paresis, multi-segmental hyporeflexia.
Hyperreflexia.
Hyperreflexia.
Yeah.
Yeah. I wrote not in very large capital letters there. Okay, have another go at this and again come back with questions about what you're finding here. All right. All right, if nothing else, you know what you've got to look at. All right, good. So,
Thanks, Jim.
we'll
Thanks,
see you
Jim.
next week.
Yeah, thank you, Jim.
All righty.
Have a good week, everybody.
Thanks.
As well. Thanks.
Bye.